This week on the BackTable podcast.
The advice that I would give somebody who was thinking about it would be to actually physically go visit places and to put that into your plan. Like, I'm going to visit before I do it. And before I even start construction, I'm going to go visit somebody else, and then staged visits because you need different pieces of information at different times. And you don't realize till you're there, and you don't realize till it's too late. By luck, I think, I kept making these visits. I visited maybe 8 different OBLs and outpatient centers over the past 5 years just to get, new advice and new perspectives on how to do things.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor.
Trying is believing. Nothing compares to trying a device in your own procedures and with your own patients. That's why Medtronic invites you to experience the Abre Venous Stent and see what makes it different. Learn more about Abre at www.medtronic.com/Abre Stent. This discussion is supported by Siemens Healthineers. Venturing into outpatient care? With clinical, business, and financial decisions to consider, it may feel like you're exploring new territory. And the stakes are high for you, your patients, and your practice. Now imagine you have an experienced partner to help you create a successful, sustainable practice. Feels like a relief, doesn't it? Siemens Healthineers is here to empower you in every care setting, every step of the way. Visit siemens-healthineers.us to discover how healthcare providers leverage the specific expertise, products, and services from Siemens Healthineers to meet their unique outpatient care goals. Now, back to the episode.
Hey guys, welcome to the BackTable podcast. You are joining us live. We got Aaron Fritts, Don Garbett, and myself, Chris Beck. We are at, what's the city that we're at?
We're in Palm Springs.
Okay.
Yeah,
I keep seeing like downtown La Quinta or...
La Quinta. Yeah, we're actually just outside of Palm Springs, but I think it's easier to just say we're in Palm Springs.
So we're in Palm Springs, California, and we're recording live. So this is a little different from our normal recording sessions, but we're recording live from WAIS, and we got Don Garbett here, and we're going to talk about private practice. We're going to talk about culture. Yeah. So Aaron, you want to introduce yourself?
Yes, Aaron Fritts here. Excited to be in person with these guys. Welcome, Don.
Thanks, guys. Don Garbett. Super excited to chat with you guys.
Tell us what's been your favorite session so far, guys.
I really enjoyed the private practice session. I have a vested interest in it, though, so I think it affects me.
Yeah. So we're on, what is it, day 2 of the conference? I liked the OBL sessions. Like every time I hear about OBLs, it gets me very interested in doing an OBL. Like, so in my group, we don't have an OBL. It seems like we don't have the impetus to get an OBL. And so I love hearing all the talks about the good, the bad, and the ugly. Sounds like it's more good than ugly, though.
There's some ugly details.
No doubt.
We'll get into that.
And actually, some of the speakers did get into that, some of the ugly details. I mean, it's not all rosy, but one of my old attendings, I think I told Don this, like he was saying, like, everyone's always talking about their job and the good things, the bad things. And he's like, the grass is actually greener in the OBL. He's like, it's much greener over here. They love it.
Yeah. And so my favorite session it was part of the private practice makes perfect. I really liked Valerie Aggioso. She talked about locums and how she didn't enjoy her first job. And then she found all these locums opportunities. And I got a chance to talk to her with Allie outside. And it's just so interesting how there's all these opportunities now. But I just thought that was a good
I think that was. And, it's funny seeing more and more people do it. Mm-hmm. And even, it's not like I'm not looking too. We're all looking.
Yeah. It's not just Kavi anymore.
Yeah. Yeah. There's great opportunities out there. And there's, you can pivot, a week here, a week there into a trip with your family to go somewhere different.
Yeah. And that's what she said sounded like she was doing. It was like she was finding locations that like she was highly interested in being, like West Coast and then family on the East Coast. I don't know. Yeah. It's something very cool about that locums lifestyle also.
Yeah.
Yeah.
And then
she also gave like some of the downsides to it. Like,
she did.
Yeah. I thought that's what's been nice about WAS. Like a lot of fair and balance, like showing both sides of everything.
Yes, you're right. Nobody's been like, this is it.
It's all cheerleading
with this. Yeah. And then the tied for first is obviously Call of the Wild by Don Garbett. Don, can you give us a little summary of what you talked about? And I think it was like frustrations that everybody feels.
Yeah, it was funny because I didn't realize, when you're in it, you don't realize everyone else has the same struggles.
Yeah.
And we have a Twitter share chat where we share our frustrations, bad cases, good cases. And I shared with Sabine my frustration that I was dealing with in hospital administration and just practice work being overloaded, things that cause burnout, like working late days and not being able to see family, and then having to explain to your family why you can't be home more. But it's funny because it does affect everybody in our field. It's not just IR, it's everybody else. But yeah, so there was a long exchange between myself and our CMO and a bunch of other specialists in our hospital, and there was this uniform response of, I don't have time for that. And it was lumbar punctures and dialysis catheters and all the things that really don't require an interventional radiologist to do, but then that we are not stuck, but you end up doing.
One thing that Chris pointed out while you were giving your talk was, the story about you built this robust program with APPs that were doing all this stuff, and all of a sudden they're gone. And then that was just like, that ruined everything, right? Because it sounded like things were going gangbuster before that.
Yeah, it was going well. We had a lot of clinical support. I think a lot of practices have done the same, where we're able to do so much more and everybody gets used to it, where, the hospitalists are like, they just expect these things will all be done. And then, what I kind of gave was that during COVID, you had a lot of people considering, do they want to be in healthcare? And, as a physician, you've already chosen, but the PAs and the NPs, they have a lot more flexibility in that they can kind of switch careers a bit easier than we can, or just retool and do a different specialty. And so, we had 6 mid-levels doing a lot of work, high-level consulting, doing all the rounding and follow-ups. And then suddenly when they're all gone and you got 15 consults on your board and you got 8 hours of cases to go and you get to work and you're just disheartened. And then you're trying to figure out, how do I pick up these pieces?
But the cases at the mid-levels help complete are some of those cases that it doesn't necessarily require an interventional radiology skill set. It's like the LPs, the paras, thoras, those are the things that are very nice to have taken off your plate. And so that's what that to me was how crushing it was. It's it's not like you just had a full board full of very satisfying cases. It's there's just cases where, in our practice, sometimes we say it, a little bit tongue in cheek, but we say we got to take out the trash, the paras, thoras, drainages, those kind of things, the LPs.
Well, it's funny, you were talking about how when you pushed back and said, can't the hospitalist do these paras, right? It reminds me of now that all the APPs are doing a lot of these things, you can't even go back to your DR guys because they're like, well, I haven't done one in forever, right? That's their excuse too. And even though they're fully capable of doing, but it's just that I'm too busy to list. I haven't done one in a year, whatever. It's like, okay, well, let me train you up. It takes 5 minutes, Well, did you guys try that at all with your own DR?
Well, yes. Yeah. And honestly, what happened was it wasn't just that they haven't done it in so long. It was that we've all adapted to this and we've functioned lean. And so where in the past, maybe there was time for these things, for the diagnostic rads to go do an LP, we're functioning with fewer radiologists to get the work done. And so now, we haven't staffed to the level that we need because we had all those mid-levels. So we'd have to hire another rad.
Yeah.
It's another diagnostic rad. It's not just about the ability to do it. It's about that availability to do it. And so we haven't staffed to that level to do it. But neither has any other specialty.
That's right.
And so that, for the listeners who weren't at the talk, when you talk to the ER, their answer is, I would love to do it, but I'm too busy. And the ICU doc, I would love to do it, but I'm too busy. And the neurologist, I would love to do it, but I'm too busy.
Yeah.
But then my response to them and this was in a Zoom call or a Zoom conference, was, well, if you being too busy doesn't mean that I do your work for you, and vice versa. If I'm too busy, I don't ask you to do my work.
Right.
And none of us own these procedures.
Yeah.
So now who's getting it?
Yeah. It's like we always talk about IR ownership, like you want to own the patient and everything, but there's like a handful of things that you kind of don't want to own. I mean, maybe like that, I just don't know if that's the answer, is like, oh, like we just have to own the patient. There's some procedures that are kind of worth like pushing back on. Like in our practice, we've kind of created this monster, like similar to what you guys had, in that we've gobbled up all those like smaller procedures from the neurologists, the surgeons, and the internal medicine docs. And like now there's just like this skill set erosion, and yeah, it's problematic. It's problematic. I feel like maybe we made a wrong turn there.
Yeah. Well, what's interesting, Don, you're giving that talk and talking about the headaches of in-hospital medicine and with your IR/DR group. But then I know that this whole time you've been building and, you planned out, built this OBL. And so can you tell us about like that transition? When did you open doors? Tell us a little bit about the timeline from idea to like you started seeing patients.
Yeah, so I can give it fairly specific. I think first, there's the hatching the idea in your head and then presenting it to your partners to invest. And I think the timeline was like November 2019. So imagine right before COVID.
Sure.
And I
Perfect timing.
Everything was going great though. The economy was booming, everything's great, and everyone's all for it. So everybody pitches in. And then March of 2020 happens, right? And then I just said, let's not do this right now. I came out and said, let's pause everything. And then April, May, June, July hits, and I saw the real estate values drop in. And I was like, hey guys, maybe it is a good time. So then we hit the real estate market and found a space. And then I think from that point, so it's like May, June, July. So hatched in 2019, November, July 2020, we pounce on the real estate market, get something. So July 2020, and then we open the doors 2022. Am I getting that right? 2022 in June.
Oh, no, 2021, right? Because you're in COVID.
Did it take 2 years to build out?
It did.
Oh, okay. Sorry.
Yeah, July. We moved in July 1st, 2022, right? Because now it's just been over a year.
Yeah. Wow. And do you, because you were talking about how you lost all the APPs and everything, and you guys got super busy, and then you went to this period of like pushback just to get some breathing room. How did that affect the actually like getting this OBL work done as well?
Well, I tried to make some changes in the practice in moving that way. Initially, we had the 6 APPs rotating into the hospital and then the clinic, and then we have some imaging centers, so they'd rotate around. And there was this preference of all the PAs that everybody loves to just do procedures, right? So they're like, I don't want to be in clinic. So nobody wanted to be in clinic. Nobody wanted to be in the hospital. They all want to be at the imaging center doing hip injections all day and then leaving at 1:00. So at some point I put my foot down and was like, nobody goes to the imaging center anymore, sort of. Mm-hmm. We didn't just cut it off, but I was like, if you go to the imaging center and you're done with your day, come over to the hospital and help the other guy, help your partner, help your other guy out. And that was met with a lot of, I think they were just already so burnt out that when I sort of put that down and said, everybody's working until 5, let's all get out of here at the same time. They were like, I don't want to do that anymore. And I sort of ate my own words, put my foot in my mouth, and they all left. And I feel a little responsible for it. But, when you're going to hire someone to do the work, you need them to do the work.
Right.
And so we created a situation where it felt easy for them, I think, to head out. Or then maybe they felt betrayed. I still don't know.
That's tough. Like anytime you have a culture shift like that, where you're trying to, like things have been kind of set and then to like wind that back, I feel like there's always some friction involved, and I'm not surprised. But at the same time, sometimes that like turnover has to happen to then like
to get the right people.
Yeah, to get the right people to then do what you want to do. We haven't seen that with mid-levels. We don't have mid-levels, or we're actually just getting one. But we've seen that with like nursing and tech staff for sure.
Yeah.
Well, then the next step was I hired mid-levels just to work in the clinic. So they wouldn't have a greener pasture at one of their other rotations.
Yeah.
So you have one rotation, that's the clinic.
Right.
And then we hired separate mid-levels. You have one rotation, you're going to be in the hospital. And it's still in its infancy, but the clinic mid-levels have become immensely effective at doing that job. And I expect, I've just finally hired some hospital folks, and I hope that they will have the same success. Being successful at one role, more than trying to rotate around and liking one job more than the other.
For sure, because it's going to happen. There's a pathway of least resistance.
There's got to be some pluses and minuses. I can see the division of labor being like you're eking out a little bit more efficiency. People get more comfortable in their role, but also it's got to be less flexibility. Like if one of them goes out on vacation, then you can't have as much cross coverage.
It requires more people to do it.
But so getting back to the OBL, so you guys start up the OBL. How do you guys have cases that could have been at the hospital, and so you're getting consults through the regular hospital system, and you're just no, we're just going to book that at the OBL?
That's a good question. So we get referrals in kind of two ways. Okay. So we're running a consult service in the hospital, so we'll get referrals in the hospital. Consult refractory pleural effusion, liver disease, needs a TIPS or whatever it is. Let's say vascular disease, because that's something that can be taken care of in the hospital or out. So now what happened, in the old days, we just see them and, we'll do it whenever, schedule's busy. We'll do it sometime this week.
Sure.
If it's not acute limb. But now we'll see them in consult and we can say, we can effectively take care of this patient outside the hospital. This is a chronic disease. They're not in any limb threat right now. So I'll go see them, do a full consult, recommend discharge and outpatient management, and it's very easy. And they'll follow up in 2 weeks in the clinic, and we'll see if they're stable enough to do them in the OBL, or do we have to take them to the hospital because there's some coronary disease or whatever.
Is there any friction? I don't want to get too much in the weeds and how you guys reimburse your relationship with the hospital. Is there friction with the hospital? Hey, these are consults that are coming through their system, and then all of a sudden they're at your personal OBL and not necessarily connected to the hospital.
Yeah, I think that is a very poignant question, and I think it's funny because everybody addresses this question, and I honestly haven't seen it yet.
Okay.
The only real push we have with admin is, and I think I've talked about this before, is they don't want us to use the call team, right? Sure. That's their main concern, and they've never asked me if I can bring more cases.
Okay.
They've only asked me if I can schedule fewer outpatients.
Yeah.
And I'm I can do that. Yeah. I never could before.
Sure.
The conversation was always in the past, before COVID even, was we notice that you are using the call team till 8 or 9 every day. And is there any way you can schedule fewer outpatients? And they actually backed us up. We used to schedule 5. Then we were only allowed to schedule 3.
Wow.
In the angio suite.
Yeah.
So they backed us up to 3. They've backed us up to 2 now. We can only schedule 2 outpatients in the angio suite. So,
it's all going to go to the OBL.
It's all going to the OBL.
Yeah.
We still have
outpatient
tips and things that have to be done in the hospital.
Sure. Yeah.
We don't have a choice. But now I don't feel as worried about, can I get my patients in, because I can take care of them in a different place.
So I think that's great. One of the hospitals that we work at, we have a huge backlog in outpatients. And so we'll get consults. Just for example, it's a thyroid biopsy, and it's, it's an inpatient. And then my schedulers, my nurses are let's just do it now. We can get it out of the way because we have a backlog and to get in. I'm like, no, that's a slippery slope. And so I think it's fantastic to have that option. I'm not saying you want to take thyroid FNAs or OBL, but it's just nice to be able to have another place to go where you have a lot more control.
Yeah. We take simple biopsies too. We're just discharge them.
Yeah.
We'll handle it. And we'll either, we'll get them out of the hospital because they're trying to hold them there.
Right, yeah.
But I say, we'll take care of it within, 8 days, and it'll either be at the OBL or it'll be at the hospital. I don't care where it goes.
Sure.
But you don't need to make them wait in the hospital for us.
Yeah.
For more than a decade, Reflow Medical has designed and engineered medical devices that respond to unmet clinical needs. The Wingman crossing catheter with its unique extendable beveled tip and an expanded indication for CTOs. The Specs LP, created to meet the need for a low-profile version of the Specs shapeable support catheter. and the new line of core catheters that answers the call for a suite of effective tools to use in challenging PCI procedures.
Did you see the thyroid ablation one? That was pretty amazing.
Yes.
That was phenomenal.
Actually,
I text all my partners.
Yeah. So actually, we should
have that guy
Gary.
C.
Was it?
C, right?
Oh,
Yeah.
Gary Z.
Z.
Yeah.
Yeah.
We should definitely get him on the podcast to talk about it. I mean, because
Yeah.
like thyroid FNAs are kind of like the very low level.
The way he presented it was so great.
Yeah,
too.
right.
He put that PACS list
Yeah.
up
Yeah.
with
He
like
owned it, yeah.
110 thyroid ultrasounds to be read.
Yeah. He's like, I don't see a list of unread thyroids. He's like, I see ablation.
Opportunity,
Yeah.
It was great.
Yeah. And he said they were doing it in the OBL too.
But it's so true. Like when something that is like diagnostic and kind of boring turns into an intervention that's therapeutic, it's so much sexier, and you know what I mean, and just it motivates you. Thyroid FNAs do not.
Anything that's just like a different spin. I remember like doing bone marrows. I went from the Gemsheedy to the on control.
Yeah,
Just
yeah.
like,
I know.
I was like, it's just something different that like made it a little bit cooler.
Yeah.
It wore off, but I'm just saying like the on control, I was like, it's like a drill, and it was kind of fun.
Remember our episode?
I know. The episode 1 where we talked about that.
You remember? Did you ever have where you would be sweating?
Oh God,
Doing a
yeah,
bone marrow,
so
just
brutal.
all the time.
dripping.
Yeah, and I felt like that thing was going to snap off. You know, especially if it was somebody young who wasn't demineralized. It was just it's so cheap. Well, anyway, I did want to ask, how has the DR side been through this?
Yes.
Are they been supportive? Have they been obstructive? Like, how's that been?
So my group is, I feel like my group is very progressive. They let me, I should say not let me, they supported me in doing, developing the outpatient center. It's a huge investment. Without sharing too much detail, let's pretend we spent $5 million on real estate. That's a big investment. And to get 20 other docs to agree on purchasing real estate and then investing, $2 million in products and construction, and then saying, trust me.
Yeah, right.
got this.
Right. It's
We'll
going
have
to come
more
back.
cases.
It's, I look back and I'm a little bit wowed that they put the faith in me, but it's not without supervision. We have a lot of accountability. We're small practice of like 23 now, but we have a monthly meeting. We discuss the, revenue cycle management. We discuss everything, and there's all eyes on everything. And, as a private practice, you get paid with your paycheck, and then there's distributions. And is it solely, I think we held distributions for COVID, and now we're holding distributions for our center right now because it's basically afloat, because we're still getting processes nailed out and scheduling and hiring nurses. And there's all these 100 other struggles that you don't think about that start rearing their heads a year in.
Is it too early to say like whether like the OBL has been like a net positive, or because because there's so many advantages to the OBL that I think like, so a lot of times like you get focused on the money part, but like almost like for my group, even if it was like cost neutral, it just feels like it would actually be a lot of like good processes, a ton of autonomy.
More
this will be a lot
efficiency.
of satisfying
Yeah.
for a lot of reasons.
freeing up time versus money.
Yeah.
I agree. It has a lot of that, freeing up time and autonomy. That being said, we're basically revenue, since we opened the actual angio suites, because we were open without angio suites for a good 6 months.
Okay.
So we're just hitting October. We're just about to hit a year of angio suites in November. And I think in November we will hit revenue neutral.
Okay.
So we've been revenue negative for that whole time with, real estate and staffing, and we're paying people to help us get accredited, which different states require accreditation, which is a big deal. So, it's every month looking at the statement and your partners are looking at you, hey, Don. And it's not like we haven't had the conversation every month,
Sure.
but every month it's the same question. When do you see us being revenue positive?
Yeah.
And what do we have to do? How can we support you in making us revenue positive? And it's always the same conversation. But I think part of it is just you have a bunch of smart people in a room who not everybody has the same financial knowledge, but everybody's trying to contribute in some way. Or in the craziest or the worst scenario, you have one of your partners says, well, when do we shut it down? Which does come up.
Right.
And it's been said, and I don't think I've ever said, but when you're in the meetings, there's politics, right? And you have to keep a really cool head, and it's really hard it can be hard when you know something can be immensely successful, but it's not there yet. It can be really hard to keep your ego in check and not lose your temper in a room. And I think, anyone who has a spouse knows that as soon as you lose your temper, you've lost the argument or the conversation.
Right.
You've lost the conversation. Right. So you can't, it's the same. You have to view your partners like spouses, and you have to maintain your cool.
Keep it calm. Yeah.
Was there any talk about, or did the thought ever cross your mind, or that you and your IR colleagues to like carve that out, like that OBL, and like say, look, you guys don't have to worry about this part. This is us. This will be our adventure, but it'll affect workflow a little, like anything like that, where you just, I'm not saying cut the diagnostic guys out, but maybe they didn't want to be a part of it, still maintain the group integrity without like bringing everyone in the exact same business venture.
We did discuss that.
Mm-hmm.
So it was a big discussion. And I don't think that should be ruled out if someone's considering that, owning the downside more so than the other folks. But that, it's sort of it's a business decision.
Sure.
Like, we will own the downside, but then do we also own the upside? Do we take all the risk and then we split the benefits? So you have to look at that. And ultimately, in our group, we're sort of communists.
Okay.
In a radiology partnership, everyone makes the same amount of money. There's a little bit of like, I took an extra shift and we'll supplement these things. But it's kind of a pittance compared to everything else. So there was, I never put it forward because I didn't want it coming from me. But some other folks did put it forward that what if we separate off the finances and just separate it like that? But then we have a few MBAs in the group and they were like, no.
Okay.
Who were diagnostic. They were like, no, everybody shares. We share in the good, we share in the bad, and we all contribute to success. And, that outlook has been successful in our group.
Yeah. Because it keeps that cohesiveness with the group too. Because I imagine like if you guys were wildly successful, it'd create a lot of I think resentment on their side, right?
And then we'd be like, we don't need to read.
Yeah, exactly.
Yes.
Yeah, you're like, we're actually done with y'all. Like this is, that was the other question with imaging is, have you seen it? Because that's what I think is part of a lot of people's pro formas is, has it led to
downstream
increased? Yeah.
Is there an imaging component to it, or is it all just OBL?
We do ultrasound there.
Oh, okay. Yep.
We don't do CT there.
Got it. So nothing cross-sectional.
Yeah, we actually have a non-compete with our local hospital for cross-sectional imaging. We do x-rays, but we don't want to do x-rays.
Yeah.
Because we have a joint venture for imaging.
Sure.
But the imaging that counts, MRI, CT, like you're bringing patients in.
The downstream.
Yeah, exactly. Like, have you seen that?
So we did some initial looks at the downstream revenue from what we order imaging wise.
Yeah.
But it's hard to track because then what happens is I order some imaging and then, there's patients that we have that the oncologists have too, and they order the imaging. So is it my downstream or is it their downstream?
I see.
But we did look at it and it was something like $300,000 for 1 year in downstream imaging that was directly relatable to stuff we ordered as the 6 IRs in the group or the PAs in our group. So it's not nothing. It's not zero. And I was our 51st most referrer to our imaging centers, which I took as a little prize. I'm like, I'm one of our top referrers.
Well, the last question I have, Don, is really, looking back, there's a lot of people here at Western Angio that are interested in doing something like this in their own group. I know in my group, there's been a lot of people discussing these options, and I think they just can't get that buy-in from the diagnostic guys. Any advice you have for anybody doing that? Like now that you've kind of been through it, you're open for a year now. Anything that you wish you knew?
Yeah, I think I have two things that I wish I knew and things that I would advise for someone else who's thinking about it. I wish I knew how much personal time this would have, if I knew it was going to be like 30 hours of my work week every week, I don't know. I think I still would have done it because that's just me.
Sure.
But it would have been easier. There's moments in time where you've gone down a year down a road. Yeah, I think everybody has some kind of moment when you're in med school, the imposter syndrome, or you're in residency and you're like, do I really want to do this? but I think it usually relates to, you get to a point and you're like, I didn't realize that it would be this hard. Or, I think that's where it comes from.
Sure.
The imposter thing. But yeah, I got a year into this and I was like, I didn't realize it was going to be this hard. I could just quit. I could just go to I could go do locums. I could go to another group. I could join an OBL that's already set up.
Mm-hmm.
And all these things crossed my mind. But, you are where you are and it's hard to go back. So that's the thing I wish I knew, was how much personal time it would require.
Or would that help if if your group compensated you for that time in some way, gave you an admin day to I know it's a hard sell whenever you're going into an OBL, because you have this non-entity that could be a total failure, and then to give someone's a quarter or 20% of their time to then baby it along. But it's not unreasonable that if you're the medical director of an OBL to have some carved out admin time. Maybe something down the road, but I don't know if that would make it a less nasty pill to
I think
swallow.
you're very right that the group was pretty on it.
Mm-hmm.
I think a few of them saw how tired I was all the time, and they were like, Don, do you need admin time?
Mm-hmm.
And I already had admin time. So they added another half day.
Okay.
Because I've been the IR chief for a few years. So they gave me admin day for that. And then they added more admin time for this.
Okay.
And I've been kind of wanting to hand off the IR chief to somebody else so I could just do this.
Right.
Because it's 2 full-time jobs on top of a full-time job. I think the advice that I would give somebody who was thinking about it would be to actually physically go visit places and to put that into your plan, not to just have it, sort of willy-nilly I'll visit places. No, I'm going to visit before I do it. And before I even start construction, I'm going to go visit somebody else, and then, staged visits,
Mm-hmm.
because you need different pieces of information at different times. And you don't realize till you're there, and you don't realize till it's too late. And so, I think it was, by luck, I think I kept making these visits. And so I visited Mary's lab in Portland, which is very close to mine as a drive. I visited Melton and Parsons' lab, and I visited Watt's lab. And I know I visited I visited some labs in Cali even before I hatched the idea, and a bunch of labs. I visited, maybe 8 different OBLs and outpatient centers over the past 5 years, just to get, new advice and new perspectives on how to do things.
Can you give one example of where that changed, where you're in the process and you were oh man, it was so helpful to have gone to Mary's lab, and then, I don't know.
Yeah. So I think two good points, and these might be further along.
Sure.
In the process. So I was already close to open, and I visited Melton's lab, Parsons and Melton, and I saw they have this immense efficiency. It's a huge beast. They have the 2 angio suites, and they have, I think it's 11 recovery bays.
Wow.
Because they're moving people through pretty efficiently, and they got 7 nurses running around. But I saw this one cool thing that they did, and they have separate rooms for every recovery bay, but they wrote on the glass wall times. So when the patient got back, they wrote times, and you see these things and you're like, what's the utility? But what happens is the patient gets back to the recovery room, and they write every 15 minutes as a thing on the glass. And then now, because they're sharing patients, so now all the nurses have all the patients instead of one nurse having 2 patients. So you got all this overlap. And then as soon as somebody sees on their watch and that time's not filled out, they run over there and they check the site and they check the vitals. And so everything gets done super efficiently. So that was Melton's lab, and it's just a small item, but it's something you don't think about.
Yeah.
And then Watts' lab, which is also Nick Petruzzi's lab, to give credit. What I thought was really interesting is that they were able to, one of the struggles of being in a clinic/procedure area is trying to see patients and trying to do procedures. And you schedule patients and you're trying to do procedures, and then trying to mix those 2 things can be really hard. And you don't want patients waiting an hour or 2, because then they're gonna go somewhere else.
Yeah.
And it's frustrating for everyone. So they just figured out a really good way to do it. And it's hard to relate all the details of it, but I think if you go see it, you see how it's done and you see how it can be done efficiently. Because it is, you're trying to mix seeing patients and evaluating patients and getting procedures done, which is still a struggle.
Sure.
With the manpower, imagine you're just by yourself and you have to, the surgeons do it, you have a clinic day where you're not operating and then you have procedure days. And in our structure, all the days are procedure days. So how do I get time to see patients? And this is actually the current struggle that I'm working on with my practice. So, the newest proposal is, hey, I need clinic time for all my docs.
Gotcha.
Yeah.
And they're like, well, we don't see the value in that. So right now it's still a struggle. I have PAs and we do a rounding in the morning.
Sure.
And we talk about all the patients they're going to see in clinic, and it's 40, 50 patients sometimes.
Wow.
So we'll run through every case. And if they really need me to come see a patient, they'll, grab me between cases and we'll go see patients together, which is how we're doing it now. But it's not how I want to do it
Right.
in the long term. So that's the next challenge.
Wow.
Yeah, Melton and Blake's, because they it's a surgical approach because of Jim, right? But like Blake, I went and visited them too, and it was like Blake was in clinic in the morning and procedure in the afternoon, and Jim was the opposite. They just flip-flop, and it seemed extremely efficient, And so, yeah, it's like you kind of have to have more of a surgical clinical mindset, I think.
Also want to give a shout out to Blake's talk. It was like
early.
It was like early in the morning. He's just
Yes.
like throwing up case after case, and he's like so like casual about it. He's
Yeah.
like, yeah, and we do this and we do that, and you're like,
It really
you're like
is.
looking at it, you're like, oh my god,
Yeah.
impossible.
Everything's a CTO and it's
Yes,
all
exactly.
super
He's like-
simple.
He's like, yeah, you may want to go pedal. You may have to stick like 3 pedal accesses and then like have contralateral groin access. He's like, yeah, but it takes me like 15 minutes and we're done.
He's not lying.
I know.
I saw
They're
him
super
operate.
fast.
It's incredible.
Yeah.
It was pretty neat.
Yeah.
Just how casual he was about all of that.
Yeah, but well, everybody up there, it's just like everything's laid back. You thought New Orleans was laid back, but like those guys they're pretty relaxed.
Yeah.
The one other one I really enjoyed, and I think because now I'm dealing with all the struggles I am, Maureen Coey.
Oh yeah, about UNC.
She's talking about UNC. She's talking about culture.
Mm-hmm.
And I've never really latched on to that. And I remember hearing Peter's talk about culture. You guys were like in Europe talking about stuff. And it's sort of like, popped a little bubble in my head and I was thinking about it. And then when Maureen talked about it more, I was like, yes, handwritten notes, like all these details.
Mm-hmm.
And I'm like, I don't have time to write handwritten notes,
Yeah.
but maybe I need to have time to write handwritten notes.
I know.
It's like
lunch
those
cards.
Yeah, it's like
coffee
those little
cards.
things that are like outsized gains. Sometimes I think like with our group, like when I think about like recruiting, I think like recruiting is going to be a big push for private practice. I think there's going to be, I think that's going to like make or break some groups. And I think about differentiating factors. And so I think about like ways our group could have like differentiated. Like everyone's going to throw salaries, vacation time at you, but that's like the tool that everyone has, and you're stuck with the location you do have.
Right.
Just like what else can you do? Can you offer there's that personal touch,
Yeah.
but like, I don't know, get people like, company cell phones. Like it's like those soft, like fringe benefits that
Yeah.
I kind of want to look into. But yeah, Coey certainly had like a more personal touch. It doesn't cost you anything but time, but
Yeah,
that's sometimes
Moneyball
like a
with
big
the
premium.
Coke machine in the locker room. Did you guys see Moneyball?
Yes.
Of course.
And he's like, why does it cost 75 cents?
Yeah,
He's
exactly.
like, Dad, just give them free sodas. These are professional baseball players. You're making them. You're
gotta
literally
find
nickel and
quarters.
diming them for sodas in their own locker room.
Yeah.
It's those little things, right?
Mm-hmm.
That can totally. And that's what I see us very similar to like professional athletes in terms of like you say, like recruiting, and it's all about culture.
That's a good
Because
point.
you put so much time and energy and life into training, and then to just be traded around like you're a
Mhm.
commodity, like that ruins teams, right?
Yeah.
And it ruins practices, and yeah, we're seeing it happen, and that's why we have all these locums opportunities.
It makes sense. And a lot of people are, even if you're in a group, you're sort of practicing in isolation to
Yeah.
some degree,
Mhm.
and when you're at the university, you have conferences and all these things, and that doesn't always travel out to private practice. Even in some of the smaller institutions, smaller universities, you might be kind of the lone guy at some satellite site,
For sure.
and you get like no camaraderie. And then the camaraderie is the culture.
Yeah.
And how do you make up for that?
we've seen it like ruin departments, academic places and private practice. Yeah. Nobody's immune to it.
And then like Coey kind of described like that death spiral. Like, I mean, I've seen that like come close to taking down groups. It's like you all of a sudden like a couple people leave because of a culture thing, and then all of a sudden you're short staffed, and it's like this doubt where like you can't recruit anyone because like everyone's like we're on, like you can get like 3 weeks of vacation. I mean, so I think recruitment's going to be big for private groups coming up.
Yeah. Well, let's do a culture in Lisbon at Cersei next year. And it could be
Is Cersei going to be in Lisbon?
A redact. It's going to be in Lisbon. We were just talking about it. And maybe Peter will join us. Talk about culture again.
Sure.
Well, thank you so much, Don.
Thanks for coming on, Don.
I love it. It was great to see you guys in person here.
Yeah, of course.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Don, Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sabri.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.